If you are over 60 and every morning you take a beta blocker for high blood pressure, maybe metoprolol, atenolol, or bisoprolol, yet you still wake up tired, feel slower than you used to, gain weight even though your meals have not changed, or get winded climbing one flight of stairs, then this may be one of the most important conversations you hear this year. Because here is the uncomfortable truth. A blood pressure reading can look perfectly fine on paper while your body is quietly telling a very different story. And that is where so many older adults get trapped. They go to the doctor, the cuff reading looks good, the refill gets renewed, the medication stays the same, and nobody pauses long enough to ask the question that matters most. Is this prescription simply lowering a number, or is it actually helping you stay strong, steady, independent, and better protected from the outcomes that truly matter? Because in real life, the goal is not just a neat reading on a machine. The goal is to protect your brain from stroke, your heart from unnecessary strain, your balance from decline, your energy from fading too soon, your independence from slowly slipping away. As a physician who has spent years caring for older adults, I can tell you something medicine does not always say out loud. A treatment can be common, familiar, and still no longer be the best routine choice for a certain group of patients. That is not scandal. That is not betrayal. That is simply what happens when medical evidence evolves, but old prescribing habits keep moving forward on autopilot. And that is exactly why today's topic matters. Because for more than 20 years, research has been raising serious questions about using older beta blockers as the routine first choice for uncomplicated high blood pressure. Not for heart failure, not after a heart attack, not for certain rhythm problems. Those are different situations, and in those settings, beta blockers can absolutely be valuable, even life-saving. But if your only diagnosis is plain high blood pressure, the story may be very different. In this video, I'm going to walk you through what one of the most influential blood pressure studies actually found, why some major guidelines changed their position, why so many older adults on these medications still feel tired, heavy, or less capable than they used to, and what smarter questions to bring to your doctor before that prescription gets renewed again. And let me be clear right now, this is not a message to stop your medication on your own. In fact, stopping a beta blocker suddenly can be dangerous. This conversation is not about panic. It is about understanding. It is about review. It is about asking better questions before assuming that controlled automatically means best. So stay with me, because what you are about to hear could change not only the prescription on your chart, but the way you think about aging, blood pressure, and your own health for ye. Now let's begin with the question almost nobody asks, even though it may be the most important question in this entire conversation. Why are so many older adults still taking beta blockers as their routine blood pressure medication if concerns about that practice have existed for years? At first glance, everything looks reasonable. The medication is familiar. The prescription is inexpensive. The blood pressure number often comes down. And when something appears to be working, most people, patients and doctors alike, have little reason to challenge it. But medicine is full of treatments that look effective on the surface, while the deeper outcome tells a more complicated story. And that difference, the difference between a better number and a better life, is exactly where this issue lives. For decades, beta blockers were considered a logical answer to high blood pressure. The thinking was simple. If stress hormones such as adrenaline make the heart beat faster and harder, then blocking that effect should reduce pressure on the arteries. It made sense. It sounded elegant. And for a long time, few people questioned it. Doctors were trained with it. Clinics became comfortable with it. Prescribing habits formed around it. And once a habit settles into medicine, it can stay there far longer than people realize. That does not mean anyone was careless. It means inertia is powerful. Once a medication has been used for years, it becomes part of the background rhythm of practice. Doctors know the doses, they know the expected side effects, they know how patients usually respond. Then newer evidence begins to emerge. Guidelines shift, sometimes slowly, sometimes with nuance, sometimes with disagreement between expert groups. And what happens? Not every physician changes overnight. Not every clinic updates old routines immediately. Not every patient comes in asking whether the drug they started years ago still matches the evidence we have today. So the prescription continues, not always because it is still the best choice, sometimes because it is the easiest choice to continue. And there is another reason this problem hides so well. Many of the side effects of older beta blockers do not arrive dramatically. They creep in quietly, a little less stamina, a little less motivation to walk, a little more heaviness in the legs, a little more breathlessness on the stairs, a little more weight gain over time, a little less energy than last year. Most people do not wake up one morning and say, "This pill is doing this to me." Instead, they say something much sadder, "I guess I'm just getting older." And that phrase has hidden more medication-related suffering than most people realize. Because yes, aging changes the body. Of course it does. But not every drop in exercise tolerance, not every rise in fatigue, not every creeping metabolic problem should automatically be blamed on age itself. Sometimes the prescription is part of the picture. Sometimes. So now let's talk about the study that changed the tone of this debate. Because when people hear a statement like, "Beta blockers may not be the best first choice for uncomplicated high blood pressure," the natural reaction is immediate. Based on what? On theory? On opinion? On a few experts with strong preferences? No. This shift came from outcome data. It came from researchers asking a harder and more useful question. Not just, can this drug lower blood pressure, but when real people take this medication over time, what happens to stroke, death, diabetes risk, and long-term health? That is the right question. And it led to one of the most discussed hypertension trials of the modern era, the ASCOT trial, the Anglo-Scandinavian Cardiac Outcomes Trial. It involved a very large population of patients and compared different blood pressure treatment strategies. What matters for our discussion is this. One strategy was based on atenolol, representing the older beta blocker approach, while the other was based on amlodipine, representing a calcium channel blocker approach, with additional medications added when needed. Now here is the point many people miss. Both groups were being treated, blood pressure was not being ignored, but the outcomes were not the same. That matters because it challenges one of the laziest assumptions in medicine, the idea that if two drugs lower the same number, they must offer the same protection. Ascot suggested that is not always true. Drug class can matter, mechanism can matter, trade-offs can matter. Now let's be honest and precise. The main endpoint the trial was designed to prove, a combination of non-fatal heart attack and fatal coronary disease, favored the amlodipine-based group, but that difference did not reach formal statistical significance before the trial was stopped early. That nuance matters. Good medicine requires honesty. A trend should be called a trend. A confirmed result should be called a confirmed result. But the secondary outcomes told a very important story. The amlodipine-based strategy was associated with fewer strokes and lower overall mortality than the atenolol-based strategy. And for older adults, stroke is not a footnote. Stroke can take away speech, balance, swallowing, memory, confidence, and independence in one cruel event. So when a blood pressure strategy shows a meaningful difference in stroke outcomes, that is central, not secondary in any human sense. Then came another finding that should make any older adult pause. Among people who did not have diabetes at the start, the amlodipine-based group developed substantially fewer new cases of diabetes, about a 34% lower risk than the atenolol-based group. Think about that. A medication is supposed to reduce cardiovascular risk, yet, compared with another strategy, it may push more people toward one of the major drivers of long-term vascular damage. That is not a trivial concern. That is a real clinical trade-off. Now let's move from published research to something even more personal, the part people actually feel. Because most older adults do not walk into an office saying, "I'm concerned about comparative outcome data between antihypertensive drug classes." They say something much more human. "Doctor, I just don't feel like myself anymore." That is where this conversation becomes real. They tell me they are sleeping enough, but waking up tired. They tell me they have not changed their meals, yet the scale keeps creeping upward. They tell me their legs feel heavier, their usual walk feels shorter, and the stairs seem steeper than they used to. They tell me they feel slower, softer, less steady, less motivated, less physically capable than they remember being. And many of them assume that is simply aging. Sometimes it is, but sometimes it is not. Sometimes what they are calling old age is actually a medication effect that arrived so slowly, so quietly, that nobody recognized it for what it was. To understand why, you have to remember what beta blockers are designed to do. They reduce the effect of adrenaline on the heart, they slow the heart rate, they reduce how forcefully the heart contracts. That can absolutely lower blood pressure. But the same mechanism that lowers the number on the monitor can also lower the body's sense of momentum. Your heart is not just a pump for sitting still. It is the engine that helps you stand, climb, walk, carry groceries, recover from effort, and feel physically capable in your daily life. When that engine is deliberately held back, some people do perfectly well, but many older adults do not. They feel slower. Not just emotionally slower, physically slower, as if the body no longer responds with the same ease it once did. And because the change often happens gradually, people adapt downward without realizing it. They walk a little less, they sit down sooner, they avoid stairs when possible, they skip outings, they rest more often. The world becomes smaller, one quiet adjustment at a time. Then comes the weight gain. This is another place where people often blame themselves too quickly. They say, I barely eat more than before. Why am I heavier? Or I feel puffier and softer, and I don't know why. And while body weight is always influenced by many factors, beta blockers can absolutely contribute to that picture in some people. When exercise capacity falls and heart rate stays lower, daily energy expenditure often drops without the person ever making a dramatic change. Fewer steps, slower walking, less willingness to keep moving when the body feels heavy or winded. Add that up over months and the body changes. There may also be a metabolic layer. If blood sugar begins drifting upward, fatigue rises, abdominal weight increases, inflammation grows, and the person starts feeling as if their body is becoming harder to manage. That is part of what makes this so frustrating. The patient often blames themselves. They think they have become lazy, undisciplined, weak, less resilient than other people their age, when in reality the medication may be shaping the terrain underneath them. And this is why I care so much about the phrase controlled blood pressure. Controlled for whom? Controlled at what cost? Controlled in what context? Because if a person's blood pressure looks good, but they now feel exhausted, heavier, more sedentary, and less like themselves, then the conversation is not finished. We may have solved one problem while quietly worsening 3 others. There is another effect many older adults struggle to describe, but once they say it out loud, it becomes unmistakable. They feel like their body hits a ceiling too quickly. They begin a walk and feel fine for a minute or two. Then suddenly, it is as if the body refuses to give them any more. They climb the stairs and get winded faster than expected. They try to carry something light and feel strangely limited. They do not always feel dramatic chest pain. They do not necessarily feel sick. They just feel capped, held back, like the body cannot rise to the occasion the way it used to. That sensation matters more than people think, because movement is not just exercise in older age. Movement is independence. The ability to tolerate effort is tied to balance, strength, blood sugar control, cardiovascular health, mood, confidence, and cognition. When a medication quietly makes activity feel harder, the downstream effects do not stay inside the gym. They spread into the kitchen, the grocery store, the church parking lot, the walk to the mailbox, the stairs to the bedroom, the confidence to leave the house, and the willingness to say yes to life. That is not a small side effect. That is a quality of life issue. Now, one reason this can happen with beta blockers is simple physiology. When you move, the heart normally speeds up to meet the demand. Blood flow rises, oxygen delivery improves, muscles and brain get what they need. But if that heart rate response is being limited, some people experience effort very differently. The activity is not necessarily dangerous, but it feels harder than it should. Recovery feels slower. The body does not have the same reserve, and older adults feel that more sharply. Why? Because they already have less physiologic margin. A small drop in exercise tolerance at 30 may barely register. At 75, that same drop can determine whether someone keeps walking every day or becomes progressively sedentary. And once movement declines, everything begins to slide. Strength drops, balance weakens, glucose control worsens, confidence shrinks, social activity falls away. The body becomes less dependable. This is exactly why medication review matters so much. Because if a patient says, "Since I've been on this blood pressure pill, I can barely tolerate walking the way I used to," that should never be dismissed as vanity or impatience. That is clinically relevant. That is useful information. That is a signal that the current plan may be protecting one number while quietly undermining the physical capacity that keeps the patient healthy in the first place. Now let me be balanced and responsible. Not every person who gets short of breath on stairs should assume the beta blocker is the cause. Breathlessness can come from heart disease, lung disease, anemia, fluid retention, deconditioning, or many other conditions. This is not about diagnosing yourself from a video. It's about noticing patterns. It is about saying something. Now we need to talk about one of the most underestimated dangers in older adults on certain blood pressure medications. I am talking about that brief moment of dizziness when you stand up, that lightheaded spell, that sudden wave of weakness, that strange sensation that the room shifts for 1 second when you rise from bed, stand from a chair, or get up during the night. Many people brush it off. They say, "I stood up too fast." They say, "It only lasted a second." They say, "That happens when you get older." But in geriatric medicine, small symptoms can carry enormous consequences. Because for an older adult, a brief moment of unsteadiness is not just a symptom. It can be the first link in a chain. Dizziness, loss of balance, a fall, a fracture, a hospital stay, fear of falling again, loss of mobility, and then a rapid decline in independence. That is why this matters. When you are sitting or lying down, gravity is not pulling blood downward the same way it does when you stand. The moment you rise, the body has to react quickly. Blood shifts. The nervous system responds. Blood vessels tighten. The heart adjusts. All of that is supposed to protect blood flow to the brain so you remain upright, clear-headed, and steady. But when that response is blunted by age, dehydration, illness, or medication, the brain may briefly receive less blood flow than it needs. That is when people feel faint, dim, weak, or unstable. Sometimes it lasts only a second, and that is exactly why it gets ignored. Because people assume that if the symptom passed, it was harmless. But the fact that it passed does not make it safe. In older adults, the most dangerous symptom is not always the loudest one. Sometimes it is the short, ordinary, repeatable symptom that keeps happening until one day it happens at exactly the wrong moment. On the stairs, in the bathroom at night, in the kitchen while carrying something, outside on uneven ground, or halfway across a parking lot. And when a fall happens after 70, the consequences can be devastating. A fall at 30 may mean bruises and embarrassment. A fall at 75 can change the course of a life. A hip fracture is not just a broken bone. It can be the event that starts everything moving in the wrong direction. Hospitalization, loss of confidence, less walking, more dependence, less social contact, and a body that becomes weaker because fear has replaced freedom. This is why dizziness deserves respect. Not panic. Respect. If you have noticed that you feel lightheaded when standing, especially if it has become more frequent, more intense, or more tied to medication timing, that is worth bringing to your doctor. Do not wave it away. Do not assume it is normal. Do not wait for the first fall to take it seriously. Because protecting blood pressure is good, but protecting balance is good too. Protecting bones is good too. Protecting confidence is good too. Protecting the ability to live in your own home is good too. So now let's bring everything together into the most practical part of this discussion. Because information is only useful if it changes what you do next. And for most of you, the next step is not throwing away your medication, not panicking, and not trying to out-argue your doctor with internet fragments. The next step is calmer than that and much more powerful. It is walking into your next appointment prepared with better questions, prepared with real observations, prepared to have a thoughtful conversation instead of a rushed refill. Because modern blood pressure care offers more than one path. Calcium channel blockers, ACE inhibitors, ARBs, and thiazide-type diuretics may all be reasonable options depending on the person, the age, the kidney picture, the metabolic picture, and the overall goal of care. Some may control blood pressure while allowing the body to feel less capped during walking and daily effort. Some may fit better when blood sugar is borderline. Some may help protect the kidneys. Some bring their own side effects, of course. No class is perfect, but the point is this: you are not limited to one old routine just because that is what was started years ago. So what should you ask? Start with the foundation. Ask, was this beta blocker prescribed specifically for uncomplicated high blood pressure? And does that still reflect current recommendations for someone like me? That question is respectful, precise, and current. It forces the visit to move from autopilot into review. Then ask, could this medication be contributing to my fatigue, reduced exercise tolerance, weight changes, dizziness when standing, or rising blood sugar? Notice the strength of that wording. You are not making an accusation. You are inviting clinical reasoning. Next, ask, given my age and overall health, would a calcium channel blocker, an ACE inhibitor, an ARB, or another option be a better fit for me? That question moves the conversation from complaint to solution. Then ask, have my fasting blood sugar, kidney function, and lipid levels been checked recently in light of this medication? Blood pressure treatment should never be judged in isolation. If one number improves while other markers drift the wrong way, that changes the picture. And finally ask, I've been on this prescription for a long time. Would you recommend a formal medication review now instead of simply renewing it again? That question interrupts routine. And sometimes that interruption is exactly what good care needs. Now here is how to prepare before you go. For the next 3 or 4 weeks, keep a simple log. Track your morning blood pressure. Track your energy level from 1 to 10. Track any dizziness when standing. And if you want one more useful item, track exercise tolerance. How did your usual walk or stairs feel that day? Doctors think best with patterns. And now the most important safety rule of all. Never stop a beta blocker suddenly on your own. So let me leave you with this. If you are over 60 and you have been taking a beta blocker for years simply because that is what was started long ago, this conversation is not here to frighten you. It is here to wake you up, gently, clearly, and respectfully, to one important truth. An old prescription is not always the same thing as the best current plan. And that matters, because good blood pressure care is not just about lowering a number on a screen. It is about protecting your brain from stroke, your heart from unnecessary strain, your balance from preventable decline, your metabolism from quiet damage, your confidence from shrinking, and your independence from slipping away one unnoticed symptom at a time. That is the real standard. Not just is the blood pressure lower, but is this person better protected? Is this person functioning well? Is this treatment supporting the life they are trying to keep? If this conversation described you, if you have felt more tired, more breathless, less steady, heavier, slower, or more limited than you expected, please do not dismiss that too quickly as just aging. Aging is real. Nobody should insult your intelligence by pretending otherwise. But sometimes what feels like aging is actually a treatment plan that deserves a second look. And when that review leads to a better fit, the result is not minor. It can mean a better walk, better balance, better confidence leaving the house, better energy in the morning, better participation in family life, sometimes even better long-term protection. But I want to end with responsibility, because this part is absolutely critical. Do not stop a beta blocker suddenly on your own. Not after hearing this. Not because you feel worried. Not because someone in a comment section told you to. These medications must be reviewed properly, and if a change is needed, it must be done gradually under medical supervision. That is not a technical footnote. It is one of the most important safety points in the entire discussion. So here is my hope for you, that before your next appointment, you write down your questions, that you track your blood pressure, your energy, and any dizziness when standing, that you stop accepting routine refills as the same thing as thoughtful care, that you ask for a real review if no one has stepped back and reevaluated this prescription in years. And most of all, that you walk into that room not afraid, but informed. Because informed patients often get better care. Not because they are argumentative, not because they are suspicious, but because they help make the conversation more accurate, more current, and more personal. Medicine evolves, your body evolves, your treatment plan may need to evolve too. That is not failure, that is wisdom. And if this message helped you see your prescription in a new light, share it with someone else who may need the same reminder, a parent, a spouse, a sibling, a friend who has been taking the same blood pressure pill for years without ever being told that another conversation might be worth having. Sometimes the biggest change does not begin with a new drug. Sometimes it begins with one better question.